questions, no problem. I'm EJ Priholis. I'm one of the clinical geneticists at Greenwood in the Columbia office. So I know some of you, but haven't had the chance to meet a lot of you over the last couple of years. But I've talked to some of you on the phone. So if you ever have a question or something comes up regarding genetics, feel free to chime it out or give us a call out and let us know. But today's talk is on growth disorders. I haven't given this lecture before, so it's just a little bit of lots of things, pretty informal, but if you have questions, just let me know. We might have time afterwards. Okay, so I'm going to start sharing my screen. If you guys have trouble seeing it or hearing me, just let me know. So today I wanted to just kind of start from the beginning. So talk about different types of growth concerns. You know, they can be genetic or multifactorial, including environmental causes. But of course, today's talk is going to be primarily on genetic causes. So we'll review a few different conditions with a few different phenotypes. And hopefully you'll be able to recognize some patterns and descriptions of a few conditions. All right. And so these should look pretty familiar. Typical growth curves for length and weight. And we know that there are those also for head circumference for typically growing children from birth to 3 years and as well as older. And these are used during regular pediatric visits, but we use them a lot as well in genetics just to kind of get an idea of how individuals are growing. We also know that with certain conditions and certain genetic syndromes that have been well described, there are special growth curves as well for those individuals, like individuals with Down syndrome. So there are differences in growth that can include whether individuals are short in stature or tall in stature, and conditions that you might think of can include Achondroplasia, Turner syndrome, and Noonan syndrome for those with short stature. And then those that are taller, some of the more common genetic syndromes one might think of are Marfan syndrome or Soto syndrome. And you can also think about growth in terms of whether individuals are small altogether or have microsomia with primordial dwarfism, or syndromes where there's macrosomia, so full body is overgrown, like Becca with Wiedemann syndrome. And then there are those conditions where there are only segments of the body that may be overgrown, like with PIK3CA spectrum disorders, undergrowth of particular areas like hypotrophy of a limb in Russell Silver, or reduction, limb reduction defects like in Cornelia de Long, and then amniotic band, again, not genetic, but where there may be a reduction defect in the limb. We'll just review that again, differences in growth can include failure to thrive versus obesity, where in failure to thrive, there may be lots of different reasons. Again, they may be environmental, but they can be caused by single gene disorders, chromosome abnormalities, or metabolic conditions. And then where obesity might be seen can include conditions like Prader-Willi syndrome, leptin deficiency, or Bardet-Biedl. And then Again, differences in growth might just include specific areas, like in the head size. So individuals can have microcephaly, say there's a CMV infection, or specific microdeletion syndromes like 22q11, or Williams syndrome, where head sizes can be small. Or there may be single gene disorders where microcephaly is involved, versus macrocephaly, where head sizes are measuring large. That can be identified in individuals with P10, pathogenic gene changes, where individuals can have macrocephaly and autism and specific skin findings, or Fragile X syndrome, where individuals typically have larger head circumferences and developmental and learning difficulties. So just to go through, we won't be going through all of these conditions, but I did want to touch on several of these, and several of them will go into more detail, where some of them we'll just kind of gloss through to kind of give you an idea of the physical features that might be identified or recognized. So with short versus tall stature, there are a few things that we want to think about. Is it proportionate, or is it disproportionate? Where are they on the growth curves? Are they significantly off the growth curves, or are they just above or just below? How are they trending? And again, the degree. And then what is the family history? Is there a specific condition related to different growth patterns? Or are there just general trends in family heights that may suggest short stature or tall stature? And are there other medical issues or developmental issues that might make you think of other syndromes? So all of you may see specific features of this individual who has, let's say, hypertelorism with epicanthal folds and ptosis. The palpebral fissures are narrow. The ears might be a little low set. There's some wideness to the neck or webbing. And then this individual comes in for short stature, and she has normal intelligence. And an echocardiogram might show characteristic congenital anomalies, including bicuspid aortic valve or coarctation. If we dug deeper, there may be a history of a horseshoe kidney or lymphedema. And so many of you might notice some of the physical features that are consistent with Turner syndrome. And this is due to chromosome abnormality, where one X chromosome is either lost completely or has partial deletion. There are particular features that individuals might find or see that make you think of Turner syndrome, and these are listed here. So again, individuals might just present with short stature, or they might have had prenatal genetic studies during their mother's pregnancy. There may be a history of hydrops, or heart defect, or issues with puberty and menstruation. And I just wanted to show you this slide, particularly because there are clinical practice guidelines for the care of girls and women with Turner syndrome. And it's a helpful resource for families as well as clinicians that goes over a lot of the health surveillance guidelines and recommendations for treatments. All right. And so another condition where an individual may have similar features to a child with Turner syndrome, particularly another girl with short stature and who may have a webbed neck, widely spaced low set nipples and lymphedema. Some individuals might have other particular heart findings that can include hypertrophic cardiomyopathy or pulmonic stenosis. And so one of the differentials for short stature and features that could be consistent with Turner syndrome, where there is a normal karyotype, one can think of Noonan syndrome. Most individuals have a pathogenic change in the PTPN11 gene. This is an autosomal dominant condition, so any affected individual has a 50% chance with each pregnancy or with each child to have the condition. We said that most individuals have a change in PTPN11, but there are several other genes as listed here that show you that these have also been associated with Noonan. Sorry. So just to kind of remind you that with different conditions, there can be multiple genes associated with particular syndromes. And if one test was negative, that doesn't mean that there may be other genes that have similar phenotypes or the same phenotype. And also just to share, for Noonan syndrome, we talk about widely spaced eyes or down-slanting palpebral fissures, and they can have ptosis with a triangular shaped face. And I think, some of these features can be quite characteristic in individuals, but as we know, not everybody fits the textbook. And this is just a kind of a compilation of facial pictures of individuals who have been diagnosed with Noonan syndrome. And as we learn more about diverse populations, we learn about the variability in physical findings and facial features. So just a reminder that not everyone is easily recognizable by their facial phenotype, and genetic testing can be helpful. So next, on to another condition, but much more significant in terms of short stature, so achondroplasia. It's the most common cause of disproportionate short stature, so variability in limb length or shortening of limb length. And so individuals can have rhizomelia, so shortening of the proximal area of the limbs. These individuals can have particular hand findings with trident hand appearance, meaning that the kind of the fingers are kind of positioned in a way that looks like the trident, looks like a trident. Individuals can have macrocephaly with frontal bossing and mid-face hyperplasia, which might be more identifiable if you're looking at individuals by profile. And then as individuals begin bearing weight, you may see more bowing of the tibias. So again, short stature with disproportionate limbs, and the average height is about 4 to 4.5 feet at adult height. In infancy, individuals can present with hypotonia, and you may see this as more laxity in the limbs, particularly when they're young. So motor milestones may be delayed, but typically intelligence and lifespan are normal. And again, just a reminder of different growth charts for different conditions. And I'm having a hard time with my cursor here, sorry. So again, different growth charts. So as you can see, the colored areas are where individuals with achondroplasia would typically chart along for height and age. And also noted here with the macrocephaly, as you can see, individuals typically will have larger head sizes compared to the normal curve in the dotted lines, both for males and females. Achondroplasia is caused by autosomal dominant pathogenic variants in FGFR3. That's fibroblast growth factor receptor 3. And it's typically caused by a single nucleotide change, the first one being the more common one, and the second here, both leading to the same amino acid change, causing a gain of function and achondroplasia. So most individuals with achondroplasia, 80% have this condition as a de novo change. So neither parent is affected. It's nothing that the parent did or didn't do to cause this change, but a sporadic change causing achondroplasia. But we do know that in some cases, individuals do pass on the condition to a child. And so I just wanted to put out these Punnett squares to remind you of inheritance patterns. So in the bottom, so you might see this where one parent has achondroplasia, and that's designated by the big A and the little a, and then one parent may have normal stature designated by little a. And remember the combinations, individuals can be either affected, carrying one big A and one little a here and here, or two little a's. So in this case scenario where one parent has achondroplasia and the other has normal stature, recurrence would be 50%, and then there would be 50% chance of their children not being affected with each pregnancy. But we also know that individuals with achondroplasia may also have a partner with achondroplasia or another skeletal dysplasia. And so this has to be taken into consideration as well. And depending on the combinations, there may be different severities of conditions. But just as an example, for individuals who have achondroplasia with both parents affected, there would be 25% chance that there would be a case where both of the achondroplasia genes are inherited, and that leads to a lethal phenotype with the thanatophoric dysplasia, basically very small bones and short, long bones, resulting in small rib cages and pulmonary hypoplasia. And then 50% chance of having achondroplasia and a 25% chance that they are not affected. Great. And so there are various health surveillance guideline updates and publications for different conditions, including Turner syndrome, and then this one for achondroplasia. So if you ever have a patient with a particular condition, it's always nice to kind of look to see if there may be health supervision guidelines that have been published. Some of the medical complications for individuals with achondroplasia that are kind of highlighted in this type of paper would include long extremity bowing or long bone extremity bowing, middle ear dysfunction, obstructive sleep apnea, and then individuals with achondroplasia can less commonly have some of these complications, including craniocervical compression, hydrocephalus, kyphosis, central sleep apnea, and spinal stenosis. And what's nice about some of these guidelines is that they have some nice suggestions about things to look at different periods, whether that be prenatally or birth to 1 month, early on in toddlerhood and childhood and adulthood. So you can see some of these things here. And then just a reminder, like we said, lifespan is typically near normal for individuals with achondroplasia. But one of the key points I think is important to note, craniocervical ejection compression can increase the risk for death in infancy. And so some of the predictors of the need for suboccipital decompression, some of the clinical features that are helpful to note are whether or not an individual has lower limb hyperreflexia or clonus, central hypopnea on a sleep study, and important to get neurosurgery involved in terms of a proper time and specific imaging studies that might be helpful to better look at the foramen magnum and any areas that might be suggestive of compression. There are family resources out there for individuals with skeletal dysplasias, including achondroplasia, like Little People of America. And then just to review, there are some therapies, including growth hormone that has been discussed in the past, but has not shown a lot of improvement for those with achondroplasia, but it may be showing some improvement in patients with hypochondroplasia. So another skeletal dysplasia that's slightly milder than achondroplasia, that also is caused by mutation in FGFR3. Some people have kind of proposed or looked into limb lengthening procedures, but opinions about this can vary widely from center to center, from surgeon to surgeon, and it's really important if someone's considering this to have in-depth discussions with the families and healthcare team for the short and long-term complications. But there has been some promising information about new therapies or pharmaceuticals. So late in 2021, so just a few months ago, the FDA approved a drug called Silvertide. It's a natriuretic peptide analog, and it has been approved for individuals with achondroplasia who are 5 years and older who still have open growth plates. And this involves a daily injection, but it works by regulating the gene's activity and stimulating bone growth. And in the trials, participants that took this drug over a year period had about a 1.5 centimeter improvement in growth compared to those who received a placebo. So that doesn't sound like a whole lot, but I think over time and depending on how long individuals take it, a couple of centimeters for an individual who may have a final growth of 4 to 4.5 feet may be quite beneficial. And this is just a screenshot of the website about this new drug, if anybody is interested in looking at that a little bit more. How are y'all doing? Any questions so far? You're doing okay. All right. All right, we'll go to a next condition. Going on the other extreme for tall stature. So Marfan syndrome, again, as many of you know, is a multi-system disorder involving heart, the eyes, and the musculoskeletal system. And characteristic or classic features include aortic dilatation, ectopia lentis or lens dislocation, tall stature with arachnodactyly, so disproportionate tall stature with long limbs, pectus deformity, so pectus carinatum or pectus excavatum, scoliosis, and flat feet. So those that have rotated with us know that, you know, a lot of adolescents may be referred to us because this is a time where individuals may look tall and slender and may appear disproportionate and may have some pretty non-specific features like scoliosis or pectus, and just want to have an extra set of eyes, take a look to see if Marfan syndrome might be a consideration. But I think that these are a couple of things that you might be able to do in a clinic, just a couple of signs to look at. So things that we might look at are wrist signs and thumb signs. So positive thumb sign, you have the individual kind of open their hand and put their thumb in their palm and see how far your thumb or the thumb can extend past the edge of the palm. And typically I'll call a positive sign is where you can actually see the full distal tip and nail of the thumb out. And then the wrist sign, you take your wrist and hold your wrist with your thumb wrapped around with your pinky. So again, trying to see how much they overlap. And as you can see here, there's significant overlap with this individual using the thumb and the pinky with at least the distal phalange overlapping, but in this case, more than that. Some individuals just have thin wrists. Some individuals have long fingers. Doesn't mean too much, but again, a few things that might be additional clues. And then arm span. What I'll typically do is ask an individual to stand up against a wall that is flat. And so in this picture, it looks like they have some sort of stick or rod that's kind of going the length of this individual's arm span. But I'll try to pick a flat, or I'll try to pick an empty wall, have an individual stand with their heels up against the wall and flat. I'll have one fingertip at an edge of a doorway or in the corner of a room and have the other tip straightened out, and I'll mark the wall and measure that arm span that way. Then you take the arm span and divide it by the height in centimeters and see what the ratio is. And an arm span to height ratio that we call increased is greater than 1.05. All right. And then with Marfan syndrome, or consideration for Marfan syndrome, getting a good family history is important. Asking about cardinal signs and any individual with sudden or unexplained death. Marfan syndrome is caused by pathogenic change in the FBN1 gene or fibrilin1 gene, autosomal dominant with variable expressivity. So some individuals in the family may have all of the classic features, where another individual may have very milder features or difficult to see. For Marfan syndrome, about 75% of individuals have this condition as inherited from a parent. Well, about 25% are de novo, meaning neither parent is affected. So the health surveillance, again, going through the organ systems that are of particular interest include making sure that they get good eye exams to assess for lens dislocation, glaucoma, or cataracts. Skeletal features, you monitor for scoliosis, but other things that may be of concern, including flat feet or pectus. And then the cardiovascular specialists are very important in monitoring changes in the ascending aorta. So individuals may need more frequent echocardiograms based on findings, and they may be recommended specific medications or beta blockers. And then those that can cooperate with more advanced imaging studies may be recommended just to see if there may be additional findings that can't be seen readily or easily by echo. Individuals with Marfan syndrome are suggested to avoid certain things like contact sports and isometric exercise, so like heavy lifting or heavy weight lifting, because of the risk for aortic dissection. Activities that cause joint injury or pain, often we suggest with individuals who have significant hypermobility of the joints or joint laxity. There are certain medications and caffeine that are often suggested to be avoided. Individuals are suggested to avoid LASIK, and then certain activities that may increase the risk for pneumothorax. So those individuals who might play specific wind instruments or be involved with positive pressure ventilation, including scuba. And then individuals with mitral valve or aortic valve regurgitation will need bacterial endocarditis prophylaxis. Okay, so a lot of times individuals may have features of Marfan syndrome, but maybe their genetic testing was normal. And remember, there is a broad differential that can include homocystinuria, Loeys-Dietz syndrome, Ehlers-Danlos, Stickler, congenital contractural arachnodactyly, or some families might just have thoracic, aortic, and or thoracic aorta aneurysm and dissection. So depending on characteristic features or physical features you see, family history, there may be additional genetic testing if FBN1 analysis was normal, if there is increased suspicion for an underlying genetic condition. And just to review, homocystinuria is an autosomal recessive condition where you can have ectopia lentis and long limbs, but there's also a history of potential thromboembolism or developmental delay and intellectual disability. Usually the lens dislocation is inferonasal, or so down and in, versus lens dislocation Marfan syndrome being superotemporal, so up and out. And then just a couple of characteristics of Loeys-Dietz syndrome. So again, this is in the differential for Marfan, but the vascular findings are much more severe, where individuals can have cerebral, thoracic, and abdominal arterial aneurysms and dissections. They can, again, have similar skeletal findings, but the craniofacial features may also be different, where individuals have more widely spaced eyes, and bifid uvula or cleft palate may be more common. And this also is an autosomal dominant condition, so you may see additional family members with similar findings. It is often de novo, however, and these are multiple genes that have been associated with the condition. And then another condition, again, individuals who are large, who may also have macrocephaly with a broad and prominent forehead, dolichocephaly, so long face, high forehead. People with Soto syndrome can have sparseness in the frontotemporal areas, down-slanting palpebral fissures that you see in this little guy, malar flushing, and a long and narrow face with a long chin, which you may see more as the children get older. Individuals can have normal learning, but what's often typical is some history of early developmental delay or mild to severe intellectual impairment. So 60 to 80% have advanced bone age and premature tooth eruption with normal range IQ. As I mentioned, that can be a possibility. And then less than 50% of individuals with Soto syndrome have been reported with feeding difficulties and scoliosis and seizures. This is related to an autosomal dominant change in the MSD1 gene, and it is often de novo, but can be inherited. And then I'll just go through. So kind of went through several conditions with short stature, significant short stature, and then tall stature. Here are just a couple of unique features in particular conditions that we'll go through. So macroglossia and your pits or creases, a condition that you think of or might think of is Becca with Wiedemann syndrome. And so for this condition, again, the macroglossia or abdominal wall defects may be the most characteristic features that you see. If you're concerned, you want to monitor for hypoglycemia, particularly in the neonatal period. Individuals with this condition are recommended ultrasounds every 3 months until age 8, and serum alpha fetoprotein levels every 3 months until age 4, due to the increased risk for embryonal tumors that include hepatoblastoma or Wilms tumor or neuroblastoma. And then as they get older, individuals who are known to have this condition may also be suggested renal ultrasounds because of nephrocalcinosis or medullary sponge kidney disease, or could be considered additional urine studies. I just put this picture in here. This is the posterior helix of the ear. And so oftentimes people will talk about ear lobe creases on the anterior portion of the ears, but if you're not looking, you may not see these. So just take a close look if you're considering or questioning this type of diagnosis. All right, and then segmental overgrowth. So is the overgrowth isolated? Is it just leg length discrepancy? Is it the girth of one limb being bigger than the other? Is it noticeable from across the room, or is it just kind of, the subtle differences that we all have? Or are there other features that may be suggestive of a syndrome like macrocephaly, vascular anomalies, lymphedema, or macrodactyly, where there may be just overgrowth of particular fingers. And so I show this photo that's been published of a little boy and his sister. And so you can see the differences in the siblings, where this little boy has some differences in kind of the skin. So there are some faint vascular markings that you notice. There's some asymmetry in the face. Measurements, he's got a large head size, and then there's some differences in the leg length as well as leg width, and you can see some syndactyly of the toes here. And this individual, it has a condition called Mcap, or Megaloencephaly Capillary syndrome. And this condition is kind of encompassed in what we call PIK3CA related spectrum disorders, or PROS. And again, something to consider when you're seeing congenital or early childhood onset of segmental or focal overgrowth. And again, just a list of different clinical descriptions that have been kind of under this umbrella of PIK3CA. So this includes Mcap, this includes Klippel-Trenaunay syndrome, isolated hemihypertrophy in some cases, and macrodactyly. So what I wanted to say about this is that, you know, when things are focal and segmental, these are often sporadic. They're not passed down from a parent to a child. These are new genetic changes or new genetic changes that occur post-zygotically, so after conception. And so that's why only certain areas may be affected by this genetic change. And often on blood work, we may not be able to find the PIK3CA variant, but it's only on DNA testing of a particular tissue sample, affected tissue sample, that we may be able to find or confirm this change. So we'll go to reduction or hypotrophy. So an individual with triangular facies, pre and postnatal growth deficiency, fifth finger clinodactyly, leg length discrepancy, cafe au lait spots, and delayed bone age might fit into a condition that we think about with these characteristics, and short stature. And Russell Silver is a condition that we should think about with these characteristics. Again, with relative macrocephaly, so small in height and weight, but the head size may be preserved and may be 1.5 standard deviations above the weight and height. I mean, sorry, the weight and the weight and height, or weight and length. There can be prominent forehead with frontal bossing, and there can be leg length discrepancy or hemihypotrophy. So one leg smaller than the other versus hypertrophy in some of these other conditions that we talked about. These are often related to epigenetic abnormalities or UPD. So oftentimes difficult to confirm the underlying genetic cause. But we have been able to in some. Treatment, if this is identified, growth hormone may be helpful. In untreated adults, height may range below 3 0.7 to 3.5 standard deviations below the mean for males, and 4.5 to 2.5 standard deviations below for females. And a couple more things just to review. So we talked about limb reduction defects. And so you might see something like oligodactyly or split hand appearance. So a single digit here, the split appearance in the hand, or maybe just smallness of the hands and a little bit of clinodactyly here, some shortening of the fingers. The thumb looks a little kind of unique in its placement as well. But if you see these features along with facial features like this, where there may be synophorous or generalized hirsutism, long lashes that are thick, this short upturned nose that's anteverted, and a thin upper lip. Cornelia de Long is a condition that we think of with failure to thrive and some of these other physical features. Just to comment on the limb abnormalities, so about 25% of individuals with Cornelia de Long have severe reduction defects, including the upper limbs. Those that don't have severe limb deficiency may just have small hands or approximately placed thumbs with fifth finger clinodactyly, or individuals may have radioulnar synostosis that may present with flexion contractures at the elbows. And again, just characteristics of the growth. Individuals can have prenatal onset growth failure, which is present in most. Their growth is symmetric and slow, and the height and weight continues to be below the 5th percentile throughout life. There is a wide variability in individuals who have been diagnosed with Cornelia de Long, and there are multiple genes that have been associated with Cornelia de Long. So there can be variability where a lot of these classic features may not be readily seen. And then with the failure to thrive, just to remember that this may be even kind of magnified when there is a condition, but also underlying feeding issues and gastroesophageal reflux that may contribute more to the growth abnormalities. And I think that's it. So I'm going to stop sharing and just ask if there are any questions or thoughts, but otherwise, leave it at that. Well, thanks for your attention. It was good to see some of your faces since I never get to see anybody, but anyway, if you have any questions or concerns, just let me know. And you all take care.
Thank you. That was a great review.
All right. You're welcome.